So see, if you have, I told you, if you have an epicardial stenosis causing significant angina, you clear off that epicardial stenosis. You either put in a drug-eluting stent or you bypass that stenosis, then this angina is gone. Okay, so definitely patient will have symptom relief. Okay, but if you do not have an epicardial stenosis and you still have angina that's coming from the microvasculature, how will you treat it? Okay, so this again is a big headache, especially for the cardiologist as well as for the patients. Okay, so but still, there are some medical therapies that are found useful in patients with ANOCA. The first one is lifestyle modification. Obviously, this is a blanket advice. You advise nutrition, you do advise exercise, you advise stress management, weight management, and smoking cessation. The second is treatment of conventional risk factors like diabetes, hypertension, dyslipidemia. And the third one is targeted medical therapies. You should understand what the pathophysiology is. If there is abnormal vasodilatation, then it is microvascular dysfunction, then you treat them with CCBs, beta blockers, ranolazine, trimetazidine, ivabradine. Okay. If there is endothelial dysfunction and coexistent atherosclerosis, you can consider statins and ACE inhibitors. And if there is an abnormal vasoconstriction, then CCBs and nitrates are useful in this subset of population. And if there is an epicardial vasoconstriction, vasospasm, then CCB, nitrates, and nicorandil is the treatment of choice. CCBs, nitrates, and nicorandils, all these are vasodilators. Okay. By CCBs, what I mean here is the non-dihydropyridines. You give verapamil, you give diltiazem for this abnormal vasoconstriction and ANOCAs. Clear, guys?